Thank you.
Good afternoon, everyone. Prem Da. Welcome to this next and very exciting session in the National PROM Annual Research Conference. This afternoon, we're going to be talking about embedding PROMs in direct care, the view from the system. And I'm delighted to say that we have an international faculty to speak to you now, drawn from the United States of America, from here in Wales, and from Italy. And I think it's going to be a really brilliant session. We will have a Q&A at the end of the three speakers, but if you think of questions that you want to pose for a particular speaker, you can pose them in the Q&A as we go along. We'll come back to that at the end of the three speakers. But please make a note of your questions as you go through. So our first speaker is Alice Andrews, Dr. Alice Andrews, from the Value Institute for Health and Care at the University of Texas at Austin. I made reference to that in my talk earlier. Alice, it's fantastic of you to join us. Thank you very much. And you're going to talk to us about using PROMs to support relationship-centered care. But before you do, can I just ask you to just quickly introduce yourself, and we'll get the other two speakers to introduce themselves as well.
Sure, thank you, Hamish. I'm Alice Andrews. I'm the Director of Education and one of the faculty at the Value Institute for Health and Care, which is an institute jointly held between the medical school and the business school at the University of Texas at Austin. Thank you.
Thanks very much, Alice. We'll come back to you in a second. Alan.
Hi, thanks, Hamish. I'm Alan Wardour. I used to be a jobbing clinician as a paediatric intensivist in Cardiff and Vale, and I now work as the interim national programme director for the National Clinical Framework in Wales. So that's kind of in the strategy policy space. So I'll be giving you that perspective on PROMs.
Thanks very much, Alan. And Sabina, good afternoon to you.
Thank you. I'm Sabina De Rosis, Assistant Professor at the Management and Healthcare Laboratory from Sant'Anna School of Pisa, Italy. I'm responsible from the PREMS and PROMs Observatory in several regional healthcare systems in Italy, and I'm working on the public participation into decision-making processes. Thank you.
Thank you very much indeed, Sabina. So, Alice, over to you.
Great, thank you so much. Thank you for this opportunity to be on the panel today to discuss how PROMs can be used to support relationship-centered care. The goal of health transformation is clear: better health for more people. And this conference is focused on the measurements that matter to patients, what they want and need. And that's a critical piece of transformation. We can't know if we've achieved better health if we don't measure outcomes. But we want to make sure the outcomes we're measuring are supportive of relationship-centered care, are supportive of creating a system that builds relationships between clinicians, patients, and families, and a system that strengthens resilience and a sense of purpose among the clinical team. Because patients won't achieve the best outcomes with a dysfunctional clinical team, or, for that matter, with a dysfunctional operational or finance team either. Next slide, please, Gareth. So measuring outcomes is hard. It requires lots of time, steps, surveys, and many of you are involved in developing validated, verified measures. And thank you for this work. It's necessary for deeply understanding the health outcomes for specific medical condition. We also need to think about measurement across conditions and systems. And in the decade plus that our team members at the Value Institute have spent talking to patients, we've learned that while patients have different goals, we've consistently heard that outcomes fall into three broad categories. The first is capability. What makes me, me? Capability is the ability patients have to do what matters to them. And that's what many of us think about when creating patient-focused outcome measures, better functional outcomes. Whether it's about using one's feet for somebody with diabetes, or shoulder mobility for someone who's had an orthic procedure, or cognitive capacity for someone who's just undergone chemotherapy. These are all capability. We've done work with young adults aged 25 to 39 who are going through cancer treatment. Talk about capability. Some of these patients were never asked or told about the impact of their cancer treatments on fertility. Now that education is included every time and for all. The next broad measure is comfort, helping patients manage the physical suffering, the emotional angst, the anxiety that comes from treatment. For the young adults with cancer I mentioned, there was a lot of anxiety and fear about what would happen during treatment, about recurrence. And interestingly, many of them found it difficult to turn to family or friends. They were supportive, but often treated them differently. Some of these patients felt they might be judged for getting cancer at such a young age, like it was their fault. So a change was made to provide access to a counselor at the time of diagnosis, not just waiting until a mental health need arose. And finally, we need to measure what we call calm. Can life go on during the treatment of disease? Avoiding the chaos that goes along with medical treatment. Being able to manage your family, your life. For those young adults with cancer, well, cancer treatment's anything but calm. Lots of decisions and uncertainty. Patients described it as a whirlwind of information. And in the US, this is coupled with extreme financial toxicity. And then when treatment ended, there was a sense that these patients felt they were being thrown to the void, no longer having the support system. They actually felt abandoned. So the clinic added an advocate to help navigate difficult decisions and assist with outside resources. So I've used this example specifically for young adults with cancer, but this broad lens of capability, comfort, and calm is being used across the clinics at in our Dell Medical School. And almost always surfaces issues of which the medical team was either unaware or didn't realize was preventing them from delivering relationship-centered care. When you start with capability, comfort, and calm, you're starting with patients where they are. This type of measurement is inherently and deeply patient-centric and inherently and deeply relationship-centered. It's a way to communicate earnest empathy. Next slide, please. I just want to briefly mention that when we started the measurement of capability and calm for patients, the clinicians wanted to measure it for themselves. They felt it could be a way to reduce burnout and moral injury because, as you know, the past few years have been devastating for healthcare workers and has stretched their resilience beyond belief. Providing relationship-centered care that puts the health outcomes that matter to patients front and center, that focuses what is achieved with patients rather than what's done to them, supports professionalism. And it connects healthcare workers with the purpose of their profession, health. It supports resilience and a culture built on relationships and communication so that everyone, providers, administrators, and patients are working towards the same goal. Next slide, please. So just summary, thank you for including me on this panel. My contact info is here. Please reach out. I'd love to be able to continue this conversation. Thank you, and back to Hamish.
Alice, thank you very much indeed. It's very thought-provoking, and I'm sure there will be questions for you as well later on. So our second speaker is Alan Wardour, as you heard, a clinician at heart and a policymaker these days, and he's going to talk about PROMs in a learning health and care system. Thanks very much, Alan.
Great, thanks, Hamish. So it follows on from what Alice has said. So I want to give a system level view of how we're positioning PROMs and how we're trying to ensure that they're embedded at policy and strategy level in the NHS in Wales. Next slide, please. So the National Clinical Framework that I'm in charge of implementing is a document that describes how we put the strategy called A Healthier Wales into effect. And we do that by creating a learning health and care system model. Now, quality is a very important part of that model, so doing things right, but equally important is that we learn that we're doing the right things. And that's where measuring the meaningful outcomes that matter to people that Alice has just described become really important. The national clinical networks that we're creating are central to this process. Next slide, please. The learning health and care system can be thought of as having three main components. Click, please. And there's this practice to data space. So how do we enable information to be recorded from clinical interactions? Click. Having acquired that data, how do we start to understand it, develop insights and turn it into knowledge? And click. And having done that, how do we, the national clinical networks, use that knowledge to re-inform the health and care pathways that they're delivering. So this all very importantly informed by outcomes. Next slide, please. So it's important at this stage just to outline that this all depends on having a fundamental enabler of a shared data resource, a single conceptual data resource. And in Wales, this is being developed as the national data resource. Next slide, please. So thinking about that PROMs from that learning health and care system perspective, previous slide. No, that's it. Right. Sorry, I was getting confused because I'm following 3 sets of slides. Yeah, just keep them all up. Thanks, Gareth. So you've got patients recording PROMs digitally on mobile devices, and you've got clinicians who want to look at those PROMs either in their office computers or their own mobile devices, but you've also got clinicians and analysts trying to understand aggregated PROMs. And that's what forms the knowledge that re-informs the system, both for individual clinical interactions, but also for planning at system level, how we redesign pathways. Next slide, please. So thinking about those national clinical networks, and when they get together to start designing these pathways, the ask we're making of them is that they really need to consider these 2 elements, the information standards and the technical standards. So the information standards, do the human beings that are involved understand that they're talking about the same things? So are they using the same definitions and collecting the same data? And the technical standards, and how the data is stored, where it's stored and accessed, do the computers involved understand that they're processing the same data? And this requires a series of conversations between those clinicians and technical people. And in terms of the information standards and technical standards themselves, once agreed, they do need to be policed. I'm not a central control top-down type of person, but as far as information and technical standards are concerned, we do need central control and a top-down approach. Next slide, please. So looking at this individual example, there's a patient with a heart condition enters information into a bespoke app on their personal device. The data then goes to a cloud-based database owned by the provider of the app. So access to this data is then only available to users of the app through that API. The clinician wishing to access the information must use the same app or an app from the same provider as that patient. And this will be different from the application being used to view other information about the patient. So the clinician will have to have lots of different systems open. So this is the environment we're working in a lot at the moment. Next slide, please. Of course, many patients have more than one condition. So at the moment, they might have a range of different apps for those different conditions, all with kind of locked APIs and locked storage. And you can see that this is going to become quite a difficult ecosystem to navigate for patients. However, if you try to rigidly control the apps themselves from the centre, that's unlikely to make things better. The use cases are so numerous and at the moment poorly understood that we need to somehow foster the development of a learning ecosystem for these apps. And that's why it's important that we concentrate on the information and technical standards rather than prescribing what the actual apps should be. Next slide, please. So where we're beginning to move towards is if we standardise those information standards and those technical standards and use open APIs, irrespective, agnostic of the vendor of these apps, the data can start to become part of that collective national data resource. Next slide, please. In order to make things less confusing for patients, it would be really good if we could bring all those apps together behind one simple shared interface, and that's where the NHS Wales app comes into play. This is obviously a very conceptual diagram, but it shows you what we're trying to do. A very thin gateway application that maybe just deals with security and identification, and then a number of vendor-specific apps can sit behind it through open APIs and contribute to that NDR. And you can imagine a similar response happening on the clinician side. So that's the direction of travel in Wales. That's how we're trying to present PROMs at strategic level, and that's how we're actually trying to get over some of the technical hurdles at the moment. So I'm going to stop there and hand over to, well, I'll hand back to Hamish.
Alan, thank you very much indeed. Excellent summary. And you touched on the question of data to knowledge, and I'm delighted that our next speaker, Sabina de Rossis, is going to talk about that. How do we turn data into insight, the art of visualization of data? Thank you, Sabina.
Thank you very much. I'm very happy to be part of this expert panel session. Next slide, please. My topic is the art of visualizing data. We know that managing and improving care is based on measuring, so the measurement is key. We also know that not everything that counts can be measured. This premise is very important, since the way in which we measure what we represent, what we are able to measure, can provide different kind of conversations, different kind of conclusions, and different kind of decision-making process. So carrying the data visualization is very important in order to provide evidence for decision-making process. Next slide, please. What and how to represent some issues, some insights. First of all, we have to remember that behind data, behind graphs, behind data representation, there are numbers. So it is very important to provide both when we want to support evidence-based decision-making process. We also know that different kind of graphs, line bars, bar charts, spider charts, and so on, can provide different kind of information starting from the same data. So it is important also the choice about the typology of figure. It is important to provide data also in benchmarking, and we can choose to provide a comparison over time among providers or with targets, international targets, regional targets, and so on. It is important to consider the level of use of this data, system level, organizational level, individual level, since at different levels there are different purposes of use. And finally, the behavioral economics techniques are very key, are very important to consider when we design the data visualization. Next slide, please. I want to propose you one example of data visualization. It's about the performance evaluation system in Tuscany region that includes patient-reported outcome measures at different levels: macro, meso, and micro. Click, please. At the macro level, we have several kinds of data visualization. As you can see, colors are key information provided in order to, let's say, support the interpretation of data in terms of high or low performance in comparison with other providers or targets. At the meso level, click, please. We provide real-time updated data to organizations, to providers, in order to have data for improving the day-by-day practice. And at the micro level, click, please. The data are included, integrated into the electronic medical records, also for improving the communication and the decision-making processes at the micro level for individual care. Next slide, please. At the system level, the main data visualization tool is this kind of targets let's say, there is a very positive message, since organizations have to reach a target that is represented by this dark green, and we use reputational levels with this positive message in order to promote a learning from excellence process. As you can see, there are different kind of indicators, and the patient-reported indicators are one of the different information provided into this kind of representation. But we provided a new kind of, click please, a new kind of representation in order to promote another kind of conversation that is about integration of care, coordination of care, and sharing of responsibilities among providers. Next slide, please. As you can see from this slide, data are presented along the care pathway. We can see how this kind of data visualization is patient-centered, since the evaluation is along the real patient journey from the beginning of this pathway to the end. In this case, we have the perinatal care pathway. Data refers to a population of a region, of a district, of an healthcare local authority. And we represent multiple providers in multiple settings, including both data from administrative sources and data from patient surveys. Click, please. Click, please. Thank you. The red triangles indicates the PROMs and PREMs indicators. Click, please. You can focus on one specific phase of the pathway or on the whole patient journey, since it is possible to see the variability in different phases, click please, or among different providers, since we can represent also the contribution of each provider to the whole quality of care provided to this population. So framing information in this way, according to the population surveyed and the patient perspective, is a way to provide a conversation about key topics such as coordination of care, integration of care, accountability, shared accountability among providers. Thank you.
Apologies, I'm muted. Thank you very much indeed, Sabina, for that elegant presentation. So we now have an opportunity for questions to our panel. And so just a reminder that you can post those in the Q&A section on Teams. The team behind me are very kindly picking those up and forwarding them to me. So we already have a number of questions that have been put forward. A question for Alice. Thank you for your really thought-provoking presentation. How well do you find that the standard PROM tools that are in common use capture your 3 Cs, or are you having to either develop your own or bring together a consortium of PROMs to capture them?
So that's a great question. And there's actually a question in the chat that's related to this about individual conditions. I think you need PROMs at all levels. So I think that you need the standard ones. We have ITOM sets, which are very useful for really deep dive understanding. There's different levels, but the capability, comfort, and calm is just saying we need a way to make sure that we're capturing all these facets of the patient's experience with outcome measurement. And so the questions that we use are actually fairly generic and can be addressed across the clinic. So for example, in the clinics at our medical school, each department has deeper dive level PROMs, but then they're using our metrics to be able to compare across groups. That helps.
Thank you very much. So on that question in the chat, as you say, so Tim Benson from Our Outcomes says many patients have multiple conditions, but clinicians naturally focus on their own specialty. Does a focus on condition-specific PROMs matter, or should we be using more generic PROMs? And how do we address the issue of patients with multiple conditions. Alice, perhaps just, is there anything you wanted to expand about that? And if not, and also we'll perhaps draw Alan into that question as well.
Sure. You have to start with patient goals. I mean, to a patient, they're not their knee or their shoulder. I mean, we all know this. So understanding what they're trying to achieve and thinking about that holistically and having those more generic measures that we can use to understand, is the patient achieving the goals they've set out to achieve, but then having those deeper level measures so that the clinical teams can know, are they achieving the functionality that we expect them to have? How are they doing in terms of their mental health and those very more specific metrics?
Thank you. Alan, anything you'd like to add to that?
I think Alice summarises it really well. I think you need both, and I think that really important point there that Alice made, from a patient perspective, they want to collect PROMs about their condition because it informs a specific conversation they're going to have, and so I think that's the way to drive uptake and use of PROMs.
Yeah, and as colleagues will know, in Wales, we're tending to collect an EQ5D and a condition-specific PROM to allow the dual use, if you like, one for personalising conversations with patients and understanding their specific condition, but the other to allow benchmarking and resource allocation and comparison across systems and so on. Sabina, a question for you. Somebody has commented, and I would agree with this, that your visualizations are amazing. I particularly love the musical stave visualization. How long does it take to do, and is it very challenging when you have lots of different services wanting these? And I know, in fact, you deliver those visualizations for much of Italy, in fact.
Yes, thank you for the question. The data visualization I shared with you is linked to the yearly evaluation of regional healthcare systems and healthcare organizations. So in order to provide data to be included into this system, data are about, let's say, the results of a specific year. And for PROMs and PREMs, we use mobile cohorts of patient answers. In the example of the perinatal care, we follow the women along their pathway from the first quarter of the pregnancy to the first year of life of the child, and the answers of all different kind of cohorts of women that were cared in the year of reference are put together into this data visualization. Of course, for understanding if following a specific cohort results changed, we also studied different kind of let's say data to be introduced into this data visualization, and we are discussing with managers and providers if changing this kind of data visualization in order to push this patient-centered representation of data. We can provide information about the different services provided along that specific pathway. Of course, it's not easy to represent all the information we have, so there are indicators that are proxy of other kind of information. So going deeper into the system, you can have information about all the performance, all the data of the quality evaluation of each kind of service along the pathway.
Thank you very much, Sabina. Thank you very much, Sabina. I think the reality in health systems, I think, is, people are busy and there is lots of data and quite a lot of information, but people don't make the best use of it. And I think the visualizations you've shown us would make it so much easier for people who are not data experts to quickly form a view of what's going on in such an elegant way. Alice, I'm going to come to you with this next question, if I may. It's from Tim Hugenboom, and it's about the difference between private and publicly funded health systems, really. Do you expect there is a difference between privatized healthcare systems compared to publicly funded systems in terms of the types of PROMs used and the resultant resource allocation, i.e. most cost-effective treatment for a population may differ for an individual patient, which is relevant if individuals are paying for their treatment. Do PROMs in this setting contribute to healthcare inequality? Quite a complicated question, but I'd have thought from the States you might be well placed to talk a little bit about the difference between independent, private, and or self-paying and insured healthcare, perhaps.
So yes, there's several parts to this question. And I don't purport to be an expert on sort of the public-private in the US in terms of how they're measuring PROMs. I think one of the challenges that we have in all of this work is that what are the PROMs? What are they trying to get at? Ideally, if we're talking about patients' health, the PROMs that are useful shouldn't matter, except that, to Tim's point, there are different populations. There may be different needs in different segments of the population. But if we're actually measuring those outcomes, we should be able to identify the inequalities. In fact, we often talk about in terms of health disparities, which are tremendous in the US, if we're not measuring outcomes for every single patient, we mask the disparities that are happening across different populations. So again, just pushing people to think about what are we trying to achieve, not just what are we measuring, if that makes sense, because we have a tendency once we start measuring things to believe that those are the things, we get rewarded for those things, that they're emphasized. We need to keep going back to those measures and saying, are these the things that matter?
Thanks very much, Alice. And if I could just stay with you one, second. I'm not sure if I'm live. Can you hear me? You can. I think I can. Good. Yes. Yeah, if we just stay with you for one second. There is a question here. It's an international question, so we're going to ask all three of you. The use of PROMs is mandated in the UK, says Denise Frosch. I think possibly it means England, but there you are. For some surgical procedures, are PROMs mandated in other countries? So are people obliged to fill in PROMs in the US, Alice?
No, they're obliged to fill in all kinds of measures that may or may not be PROMs. You know, orthopedics is one of the easiest places to measure PROMs. There's great metrics, they're validated, they're verified. Our chief of surgery, who is an orthopedic surgeon, says that in the US, less than 10% of orthopedic surgeons are using those measures. So it's a real problem.
Okay. Alan, if I come to you, what's the position in Wales on mandating PROMs?
It depends how you define mandate, and that's a whole PhD thesis in itself. I think I really liked what Alice said there. I think it's much more worthwhile concentrating on measuring outcomes rather than measuring process or things that we can count, and continuing to ask the questions about whether it's the right thing. So I suppose what we're trying to do in Wales is we're making outcomes a really core component of the pathways that we're asking networks to devise, and it's the health boards, the local planning and delivery organisations, that will put those into effect, and they will be held to account on the meaningful outcomes that are obtained. So in that sense, they become mandated, and they become the metric, or a very important metric by which the system is held to account.
And thank you, Alan. And Sabina, in Italy, are they mandated?
In Italy, in 1992, there was a law that changed the organization of healthcare in Italy, where healthcare organizations and regional systems were invited to push to promote the collaboration of public, of population for the evaluation of quality in healthcare in terms of satisfaction, experience, outcome, but it's not mandatory, it's an invitation. So currently all the PROMs of PREMS surveys are promoted directly by the organizations in a, let's say, bottom-up process. It's voluntary, totally.
Thank you very much. Thanks very much, Sabina. I know that in France, my colleague Gregory Katz at the University of Dakar in Paris is doing a lot of work with PROMs in cataract and in hand surgery, and they are incentivizing surgeons to complete PROMs. There is a financial reward for collecting a PROM, not actually on the outcome, but on just the having collected the PROM, as a way of making that happen. And I know the professional associations are very supportive of it. And as Alan says, that if you're going to start looking at paying for care with outcome-based agreements, then PROMs become a part of that. And so in insured health systems, such as in Holland, for example, and actually in other bits of Europe, where you have an insurance-based health system, the insurers quite often do mandate the capture of PROMs along with other outcomes as part of the payment arrangement. So I think it does vary quite a lot. We've got time probably just for a couple of questions with quick answers. Emma Dunlop, what about linking PROM data alongside other routinely collected data to look at outcomes and value? So not just considering PROMs on their own, or not just purely integrating into electronic care record, but using the patient's full set of clinical and PROMs data. Any experience to offer? Alan, I wonder if you might talk about either our ambition about that.
Yes, I'd love to say it's experience, but it's aspiration and ambition at the moment. But it's aspiration and ambition that's on the way to being delivered. So the national data resource concept and the building blocks of that are in place is to enable just what's described here, because that national data resource won't just be the secondary care EHR and the primary care EHR. It will have wider data sets from social care and from the wider public sector. So very much that's the direction of travel for the NDR in Wales. Thank
you very much. And Sabina, in fact, you've just shown us data that looks at, I think, 350 outcomes, I think, or something like that you captured for health systems in Italy, including PROMs. So you are bringing together clinical and patient-reported outcomes as well, are you not?
Yeah, sure. In our performance evaluation system, data from different sources are provided together. After a process of discussion and conversation with managers and professionals in order to share indicators, targets, and evaluation processes.
Thank you. Thank you very much. And Alice, in Austin, is that what happens?
Yeah, I want to say I've been knocking on process measures a little bit here, but I don't mean to. I think process measures are incredibly important, and we absolutely should measure them with outcomes. We just always want to make sure that our process measures are serving the outcomes and not ends in themselves.
Thank you very much indeed. We've got more questions than we have time for. Let me see if I can find a quick question here. Oh yeah, right. Yeah, simple question. How live is your PROM information? Live meaning from the point of capture to point of being fed back to the clinician or the service, or indeed the patient, as this is the only way which PROMs can change actual care in the real term. Alan?
So in some services in Wales, it is live in that the truest sense. Clinicians are using it to inform conversations. I can think of myeloma, for example, where there's been a lot of work over the last couple of years led by a clinician and her team. There are examples in orthopedics as well, and there are many more that are just about to cross into usage, I think, because of that clinical network approach. So.
Thanks very much. And actually, as you say, there are many services where people are looking at the PROM prior to a consultation. Sometimes that's meaning the consultation in fact is deferred because it isn't required, but they're using the PROMs to manage patients and determine care in real time. You're right. Alice, again in Dell, is that how it works?
Our systems, I mean, data generally in the US is so far behind the UK. We're just babes in the woods in this process. So we are working to improve that, but so impressed by the work being done in Wales on all of this, and I hope to keep learning from that experience.
Thank you very much, Alice. And I think, Sabina, just perhaps to finish with you, I think in the data that you're reporting are being reported retrospectively, aren't they? They're aggregated data.
We provide real-time live data at the professional level and also the organizational level, but we provide aggregated data each quarter and then yearly into the performance evaluation system. So different time frequency for different purposes of use.
Thank you very much. I think that's an excellent thought to end on. So can I thank all three speakers? Really excellent, interesting, thought-provoking presentations, and some great questions too from the audience. So thank you very much, everyone. And I think that concludes our session. So thank you.